My topic is meniscal ramp lesion, which is very common nowadays because of this finding, orthoscopist finding this lesion very commonly, particularly with the ACL injury. So ramp lesion, originally it was described that it's the meniscocapsular junction horizontal tear, longitudinal tear in the posterior horn of the medial meniscus. But nowadays discussion is that it's not so strong a structure, that meniscocapsular junction is not so strong a structure. So this structure is not so very strong. So the consideration of the meniscotibial ligament, through which the posterior horn of medial meniscus attaches to the tibia, which is the strongest one, also taken into this ramp lesion. This is the part. So mechanism is well described very long time ago by Houston. When the knee is in flexion in around 90 degree, it is the contraction of the semimembranosus which pulls the capsule from the meniscus, and that leads to development of this type of lesion, that is the ramp lesion. So usually this ramp lesion is associated with ACL injury. Either it may be acute one or it may be chronic one. When the knee is in valgus, there is anterior subluxation of the tibia that leads to the tear of the ACL. And as ACL torn, the tibia moves further anteriorly, and this leads to the contraction of the semimembranosus, which attaches posteriorly on the medial side, and extension of this attachment also goes to the capsule. So further anterior translation of the tibia with the tear of ACL and anterolateral ligament, this semimembranosus contracts, and this leads to the developments of this ramp lesion. So about the ramp lesion exploration, so this lesion is also called as the hidden lesion or missed lesion, very well described by the Sonri Cotet in American Journal of Sports Medicine, and he says your scope should be in posteromedial gutter first, then at the border of posteromedial portal, you pass your needle and do the probing of your capsule as well as the meniscus. Like here, we can see the first you pass your scope in the posteromedial gutter, and then from the posteromedial portal side, you pass the needle and do the probing of this capsule as well as the meniscus and look for is there any separation or not. Similarly, practically also, this is the femur PCL. You enter into the posteromedial gutter with your scope. Then you pass the needle, and then you may probe here, or also if you confirm that your this ramp lesion is very clear with your MRI finding, then you can make a portal and do the probing of this part. And with the increasing knowledge of all these anatomy, the classification has been given for it. This is the normal attachment of the capsule with the meniscus, and this is the meniscus, and this is the tibia, and so this is the meniscotibial ligament. So type 1, this is the tear in the meniscocapsular part, particularly the synovial sheath. The second type is the partial superior. It's the only partial, it's not reaching to the inferior surface, and it's in the meniscus body, peripheral part. Similarly, the partial inferior is type 3. It's not reaching to the superior part. And then type 4 is complete in the peripheral part of the meniscus. And type 5 is the double tear. The same thing you can see here also in this video. This is lesion in the capsular part. The meniscus is clear. And here orthoscopically, if you see, this is the capsular part which is torn, and from here you can see the tibia also. So this is type 1. So next is the type 2. This is the partial superior part in the body of the meniscus, in the most peripheral part. So this is only in the upper part, superior part. Usually it is taken as the stable one. Similarly, the partial inferior, which you can probe from the anterior side. And If it's come entirely, then it means it's there. And when you remove the tissue from the posteromedial gutter, then this become complete. So similarly, the another type 3 part, you can pull it into the joint, so it's unstable type. And when you place your scope into the posteromedial gutter, and with the help of needle, if you just do the probing, so this the scar tissue will get away, and your the ramp lesion become very clear. Type 4 is the complete meniscal tear just in the peripheral part. So this is the meniscal tissue, which is tear from the main meniscus in the posteriorly, and type 5 is the double tear, complete tear. So this is the one type 1, and one tear, this is the another tear. So this is the type 5. So with all these classification, the treatment part is that it should be repaired if it is unstable, and repairing should be done from the posteromedial portal, lasso through the cannula, and then put the stitch there. And it's depending upon the size of the tear, it's maybe 1 stitch, 2 stitch, or 3 stitch. So so that it's become a stable one, and from posteriorly it's complete close to the meniscus. So this 17-year male boy presented to us at the 4 week of the injury. The MRI says the complete ACL tear, and also there is problem with the posterior part of the medial meniscus. And with sensitivity and specificity, this separation of the meniscus capsule from the meniscus having the highest sensitivity and specificity. You can see this separation. There is in reporting there may be irregularity or edema, but this separation is the most commonly taken as the ramp lesion MRI wise. So this again scope in the posteromedial portal, needle is there, check for this ramp lesion. So with the knife, portal was made, then the probe was passed, and you can see this much of separation of this the ramp lesion, and going from there to there. So this much of the separation was there. So through the cannula, this lasso was passed. Initially, the standard lasso I use, but nowadays there is ramp lasso is also available. So this is, and this is suture was passed over this lasso part, and the suturing is done, that is the sliding knot through this cannula, and this is there, and you can compress the tissue with the help of knot pusher. And since tear was big, then another the suturing was planned in the similar fashion, and the second stitch was placed, that is the posterior to the capsular part, so that your tissue get as much as closer to the meniscus. So these 2 stitches are there, and this closure of this ramp lesion was done. The second case, this was the chronic ACL getting managed with the rehab. Recently having recurrent locking type of sensation. It's not complete lock, but having symptom of locking for last 2 months. So plan for the ACL reconstruction, MRI was clear, only ACL tear was there. But with the history of recurrent locking in the back of mind, this posteromedial corner should be explored. MRI was absolutely fine, there was no problem. And you can see there is rent is there, and this tissue is not very good. So this chronic type of ACL, usually this meniscocapsular part is also get injured with the time. And when you probe it, this lesion will get bigger. So though it's very small, but tissue was not very good, and the chances of further injury is high. So repair was planned, and with the single suture, this get closed. So third case, again the fresh case, injury 6-week-old only. Again a scope in the posteromedial gutter with the probe in the ramp lesion. This is with the 30-degree scope. So when you use the 70-degree scope, so this much of the viewing area will find. So many recommends that for the ramp lesion, you can use the 70-degree, will give the better visualization. Nowadays, I'm using 70-degree for all my ramp repair. So again, big tear is there. So a similar suturing was, this is the first knot, and then the second knot again outside the capsule. So some recent literature over this. This is in 2018. This American Journal of Sports Medicine, the biomechanical study. What is the effect of this? And the conclusion was the effect of ramp lesion was it increases the anterior tibial translation. So many a time this type of patient will have grade 3 anterior test as well as the grade 3 pivot shift also, in spite of being there is no any other injury, only ramp and ACL will lead to such type of clinical finding. And those who are not repair for the ramp, only isolated ACL reconstruction was done, the pivot shift was still there. And those who are repair, the pivot shift was absent. Though, however, this literature says the effect of this change was minimal, but its statistically significance was found, but the clinical significance remained unclear. It was the biomechanical study. Again, research paper in 2020 about the healing status after this stability. So healing rate of ramp lesion was significantly better in those who are having repair in comparison to those who have not repaired. It means some cases those who have been not repaired get healed. So such type of finding should be decided orthoscopically, particularly with extension. When your the flap get closed, then such type of the lesion having potential for healing. Even with the extension, this flap don't get closes, then the chances of healing such type with this ramp lesion is less. Anterior laxity in the knee in which ramp lesion was unhealed was significantly greater. So unhealed ramp lesion having higher anterior laxity in comparison to those in which the ramp lesion was healed. And the final conclusion was all inside repair through the posteromedial portal was a reliable surgical procedure, and this helped in the healing of ramp lesion. Thank you.